Hello class, it's time to start our chapter on hemostasis. Hemostasis means the cessation or stopping of the flow of blood. I hope you recognize that under normal circumstances, we want our blood to remain in a fluid-like state. But there are certainly many times throughout our day when our vessels are experiencing micro tears, and we would prefer not to bleed out into our interstitial spaces. So I am actually looking at Dr. McCullough's transcripts from his lecture when he used to teach this class. And it turns out that the lecture I give on hemostasis for physiology is spot on. And in fact, my lecture points out more problems with hemostasis than what he lectured on. So for those of you who had me for physiology, you're going to get this lecture all over again. I hope you enjoy hearing it another time and appreciate the types of anticoagulants we have and how they work on a molecular level. As you can tell from this lecture outline, we're going to review the steps of hemostasis. We'll go through all 5 steps, and then I will begin to tell you how we manipulate hemostasis, and then also the different types of clinical correlations we have, like idiopathic thrombocytopenia, hemophilia, disseminated intravascular coagulation, and its equivalent in females who are pregnant called HELP syndrome. And that stands for hemolysis, elevated liver enzymes, and low platelet. And I will also upload a paper on Blackboard for you that explains this HELP syndrome. It's particularly insidious, and most obstetricians don't diagnose it correctly, and this can lead to a very high mortality rate both in the mom and in the baby. Moms usually, with that syndrome, there's about a 25% mortality rate, and the babies is somewhere up in the 60%, I believe, is what the paper said. I also have another clinical correlation, and that's antiphospholipid syndrome. And it's not on this outline, but it's certainly in our discussion. Alright, as I said before, we appreciate that there needs to be a balance in hemostasis. And I have spelled it up here with the British spelling of hemostatic balance. There needs to be a fine balance between procoagulants, or factors that would promote clotting, with anticoagulants that would promote good vascular flow, so that the blood remains in a fluid state. Excuse me. And as I say on the slide, it is normally dominant out of the 2 branches of hemostasis. Clearly, if there are problems on either side, this can lead to either inappropriate clotting if you have too many procoagulants, where then if you have too few of them, or too many anticoagulants, then you're going to have bleeding and failure to clot. So let's review platelets. I'll remind you that platelets come from the same hematopoietic stem cell called the hemocytoblast, and that one of the lineages that the colony-forming units can take is to develop into a megakaryocyte, shown here in the bottom right picture. A megakaryocyte blebs off many membrane-bound platelets. These are simply just sacs of cytoplasm and cell membrane. Inside these platelets you can have remnants of organelles, certainly some endoplasmic reticulum, mitochondria, etc. These platelets are much smaller than a traditional sized red blood cell, shown here in the picture. In a single microliter of whole blood, you would have something like 150,000 to 250,000 platelets. Anyway, these platelets are blebbing off from larger precursor cells called megakaryocytes that are found in the bone marrow. And just like we saw with red blood cell synthesis being stimulated by erythropoietin, both the liver and kidney can release a hormone called thrombopoietin, which will stimulate the megakaryocytes to increase their production of platelets. Platelets, well, they have another name, and it's thrombocyte. And cyte means cell, or mature cell, I should say. The thrombocyte is not a true cell. It does have organelles, but it does not contain a full nucleus. They cannot replicate and divide, etc. So it's really a misnomer. Just as calling a red blood cell a cell is a misnomer as well. Platelets have a much shorter lifespan compared to a red blood cell. They last in the circulation for about 8 to 12 days. Most of that is because they get consumed within that time. Again, we have a lot of micro tears in our vasculature, and that's why they get consumed. It's important to know that they have several granules inside of them. They have different types of granules as well, like alpha granules and delta granules, I should say. They have mitochondria, which can continue to make ATP and ADP, or adenosine diphosphate. And it's this ADP that's going to be released from the granules that's going to help convert the platelets to an active platelet. They still have remnants of their endoplasmic reticulum and Golgi apparatus, so they can continue making clotting enzymes, and they also can store calcium. The endoplasmic reticulum is fantastic for storing calcium. They also contain with them a prostaglandin called thromboxane E2. Now, I want to remind you from our thermoregulation lecture that prostaglandins are synthesized from arachidonic acid. It is a phospholipid that is found in your cell membranes. We require a COX, or cyclooxygenase enzyme, and there are COX-1 and COX-2, and technically a COX-3 variety. The COX-3 I won't discuss very much here because we still know very little about it. COX-1 is considered to be constitutively expressed. That means if a cell is capable of synthesizing that enzyme, then it's doing that all the time, meaning it's always on. COX-2 is an inducible type of enzyme, meaning that only when the triggers are around will cells synthesize this other type of COX. And we're going to see that it's synthesized in an inflammatory response. We're going to talk more about that in a future segment. So inside the platelets we have a prostaglandin called thromboxane E2, and it, like PGE or prostaglandin E2, is derived from COX cleaving arachidonic acid. And we're going to see that this type of prostaglandin is going to promote platelets maturing and changing their shape and becoming activated. There's also actin and myosin. These are contractile proteins inside the platelets, and they are very important for clot retraction. Once the clot has been formed, the ends of the tear need to be pulled in closer proximity so that remodeling can occur. The fibroblasts need to repair that hole. They need to develop new fibers like collagen and elastin. So basically, the cells need to repopulate, and the basement membrane needs to be recreated, and actin and myosin are basically going to hold the two torn ends closer together to facilitate that repair. Inside platelets, we also find a very important clotting factor called factor 13, also known as fibrin stabilizing factor. This enzyme is going to be very important in cross-linking the fibrin threads, and I'm going to be reviewing that with you in just a bit. There's growth factor inside platelets, and again, this is going to help facilitate the repair of the damaged endothelium. One more thing found in platelets that I don't have listed here, and I really should, so feel free to include that here, is the von Willebrand factor, or VWF. Von Willebrand factor is a glycoprotein. That means it's a protein with sugar attachments. It is not an enzyme. However, its role in clotting should not be dismissed just because it's not an enzyme. Von Willebrand factor is found inside plasma all the time. It's also found inside platelets, and it's also made by endothelial cells. Its primary roles are to carry factor 8. So if a person has a deficiency in von Willebrand, they will also have a deficiency in factor 8, because factor 8 is quickly destroyed in the blood plasma if it's not bound to a carrier. Perhaps you remember this from physiology. In physiology, I described the different kinds of hormones. There are some that are amino acid derived, there are some that are protein derived, and there are some that are steroid derived. and I talked about the lifespan of hormones. Those different hormones in the bloodstream, it turns out that proteins that are not covered by another protein are more labile. They are more easily destroyed by proteases that are found in the blood. So factor VIII is particularly susceptible to proteolysis and is going to be protected by von Willebrand factor, and therefore its half-life will be much longer. So von Willebrand factor is found outside the platelet, but also found inside the platelet. Alright, this is just to remind you of the stem cell, the hemocytoblast, creating two colony-forming units, the lymphoid colony-forming unit and the myeloid. And if we look at the myeloid, we can clearly see that it is the myeloid line that will give rise to a colony-forming unit that will develop a megakaryocyte unit, shown here from the second from the bottom. You see CFU meg, that stands for colony-forming unit, leading to a megakaryocyte, which will then bleb off platelets. So let's go through our 5 steps of hemostasis. Now, when we actually talk about forming a clot, a lot of times in a medical laboratory they will say clotting times. Clotting times are very, very different from bleeding times. We assess them differently. With bleeding times, we simply take a lancet to someone's ear, or even place that lancet along the flank of their body. We inflict a small laceration and we see how long they bleed. That is not the equivalent of how long, or asking the question of how long does it take your clotting factors to form a clot. So when we are talking about clotting times, we're talking about blood in the test tube, where we add reagents to it, and we see how long it takes for a white clot to form at the bottom of the test tube. And again, that's very different from assessing a patient's bleeding times. Bleeding times, we actually inflict a small cut on a patient and see how long the blood comes out from that cut. Alright, so hemostasis. Its purpose, of course, is to prevent blood loss through the walls of damaged blood vessels. It's also going to establish a framework for tissue repairs, which I've already discussed briefly. There are 5 main phases. The first phase is called the vascular phase, where muscle spasm and the smooth muscle found in the wall of the blood vessel is going to help reduce the diameter of the blood vessel. This is known as vasoconstriction. Obviously, a reduced outlet means less blood will be able to flow through it. The next phase is the platelet plug formation, or platelet activation phase. Very, very important phase, and filled with lots of good information that I'm going to share with you. The third phase is the actual clot phase, where we get fibrin threads covalently linked to each other. During this time, I will discuss with you the extrinsic pathway and the intrinsic pathway. Finally, we get to clot retraction, where your actin and myosin filaments will perform the sliding filament activity and help retract or pull together the severed ends. And then finally, we recognize that a clot should not be immortal. We don't want it to hang around indefinitely. Once the repairs to the endothelium have been performed, we want that clot to be removed. So we need to discuss clot dissolution along with tissue repair. As I said before, we have the vascular phase. This is going to be enhanced by a prostaglandin, thromboxane A2, found within the platelets. So the blood vessel is going to be severed in some way. The smooth muscle, like I said, is going to contract. This is vascular spasm. This is going to reduce the blood vessel diameter, and this will slow blood loss. This is enhanced by thromboxane A2, as I said. It actually can stimulate the smooth muscle to cause it to have a greater force of contraction. Thromboxane A2 is going to be clinically important to us when I get to the segment when I'm talking about manipulating hemostasis. We're going to talk about aspirin, baby aspirin, low dosage of aspirin, the low dosage of aspirin from baby aspirin will inhibit this platelet COX enzyme from making thromboxane E2. So we call it an antiplatelet. That means the platelets are less likely to be activated. But high doses of aspirin actually are going to impair the synthesis of prostacyclin, also known as PGI2. And I'm going to show you that on the next few slides. So low-dose aspirin is used prophylactically to help reduce the tendency of platelets to become activated. And I'm going to discuss this more when we get to our future segment. It's actually a really good discussion, and there's more there than what I taught you in physiology if you had me as a teacher. Okay, so let's do the platelet phase. Lots here to go through. First of all, platelets are normally repelled from the blood vessel endothelial lining due to a prostaglandin known as prostacyclin, or PGI2. Now, the endothelial cells, these are the cells that line the lumen of the blood vessel. They have a COX enzyme as well, and they make this particular variety of prostaglandin. And the PGI2 helps repel the platelets. It's really mostly because of same charges helping to repel the platelets away. When trauma occurs, either to the blood itself or to the surrounding tissues, a cascade of events will occur. And if we focus on the blood itself, yes, even platelets can be damaged. So the platelets can lyse, and they can release their granular contents. If they lyse and release their granular contents, then we get this release of ADP and thromboxane E2. Now it turns out that when ADP and thromboxane E2 mix together, and you can even do this in a test tube, they get gummy. They get really, really gooey. This is going to help all the other platelets in the local vicinity to start swelling, make these irregular shapes, extensions of their cytoplasm. They look like they have little pseudopods or false feet sticking out. And the contractile proteins within the platelets are going to even cause more granular release. So you should be hearing positive feedback. Activation of platelets leads to more activation of platelets, leads to more activation of platelets. So as the platelets change their shape, and they're going to have increased, quote, gooiness from the ADP and the thromboxane A2, it all makes things sticky, and this is going to override the prostacyclin trying to repel those platelets. As such, the sticky platelets are going to stick to the sticky endothelial cells and the basement membrane. Again, we've had some trauma to the blood vessels, so there's going to be some exposed collagen fibers. Now, von Willebrand factor, as I have said before, it's found in the platelets, it's found in the blood, and its role is primarily to carry factor VIII. Well, von Willebrand factor is also necessary to help anchor the platelets to the collagen fibers. It's going to basically act like a bridge. So again, von Willebrand will mean, or von Willebrand factor will mean that the person is going to have problems activating their platelets. I should say if they have a deficiency in von Willebrand factor. But they will also have a reduced amount of factor VIII. And I'll talk about that more in the future segment. To get back to normal, so platelets become sticky. This causes their contractile proteins to release more granules. This leads to more activation of platelets. It's all an amplified effect. The ADP with the thromboxane E2, they're going to be the primary stimuli for activation. And the thromboxane A2 is very important. Again, like I said, especially for the vasoconstriction. There's a lot of calcium ions that are stored in the endoplasmic reticulum within the platelets that will also be released. And calcium is needed as a cofactor for many of the clotting factors. Many, but not all. There are a couple of clotting factors, factors 12 and 11, that do not require calcium, which is very odd if you ever were to speak to a biochemist. So mounds of platelets are going to develop at the damaged site. I think this little mound of beans represents what a platelet plug would look like. But this is not a clot. We do not have the fibrin threads synthesized, nor do we have them fixed in place. And that means this platelet plug can easily dislodge and cause bleeding into the interstitial spaces all over again. Alright, so what did you hear? You should know that platelets are repelled from the normal endothelial lining. Platelets are negatively charged, and prostacyclin is made by endothelial cells, and this is also negatively charged, which helps repel them away from the endothelial lining. We don't want them, platelets, to come into contact with the endothelial lining. Inside platelets, we have thromboxane. We also have ADP, and these are going to be released from granules. And when the two come together, the platelets become very gooey and sticky. This is going to help with also changing their shape, making them more likely to stick together and form a platelet plug. We have von Willebrand factor. It's synthesized in different places. It's normally found in the plasma. It's made by endothelial cells. We also have some von Willebrand factor that's actually in the platelets. ADP and thromboxane A2, like I said before, are very important for platelet aggregation, and the thromboxane A2 is important for that vascular spasm. Again, at the end of the platelet phase, we do not have a clot. We simply have a platelet plug that can be very easily dislodged. This picture, if you look at the left side, you are seeing intact endothelium, and you're seeing the release of prostacyclin. Again, another name for that is PGI2, and the 2 is a subscript. This is going to prevent the platelets from adhering, mostly from charge-charge repulsion. If you look at the right of the screen, you're seeing that we have a tear in the endothelial cells, and collagen fibers are exposed. The physical contact of the collagen fibers is because prostacyclin is no longer being made in that area. And so the platelets exposed to the collagen fibers, well, they become activated. And the collagen fibers damage the platelets to release the granules. The platelets change their shape. You can see they're pseudopods. They look like little stars. And the gooiness, remember, from the ADP and thromboxane A2, all of that leads to a platelet plug. On this picture, I want to do it again. If you look at the bottom picture, you're seeing the disc-like shape of the platelets, and when they come into contact with a glass plate, for example, and they stop moving, the physical stasis, that means stop, of flow can actually lead to the activation of the platelets. So just even on a glass cover slip, they can activate on their own. When they activate, they swell, they develop these pseudopods, granules release their contents like ADP and thromboxane A2, and they get sticky. You'll see in the top picture here that we have a platelet that has a lipid receptor for von Willebrand factor. The von Willebrand factor, like I said, naturally found in the blood, is carrying factor 8, but it also acts as a bridge to help anchor platelets to the collagen fibers that were exposed in the injury site. So, very important role, von Willebrand factor. It's not just a carrier for factor 8, but also acts as a binding protein for platelets to anchor to the collagen fibers. Other ways to activate platelets? Stress. Your stress load will lead to the release of epinephrine. We talked about that in our stress lecture. Epinephrine itself, that hormone, can activate platelets. And thrombin, a clotting factor we will talk about in our third step of hemostasis, can also lead to the activation of platelets. So this positive feedback mechanism of platelets, activating platelets, is going to be exacerbated or made worse by thrombin. The actual clot starting to form can actually activate more platelets as well. Eventually, we need all of this positive feedback mechanism to ultimately be stopped by a negative feedback mechanism. Now we're to our third phase of hemostasis, and this is the coagulation phase. We're going to be playing with 12 clotting factors. They are numbered 1 through 13. Did I just make a mistake in saying that? No. 12 total clotting factors. They are numbered 1 through 13. There's just a problem with one of them. Factor 6 does not exist. The reason for that is that it was a redundant discovery. And so the second scientific laboratory that thought they were discovering something new, when in actuality they had this factor 6 that was published on, and so the second team had to wipe it off the books because it turned out to be the same as factor 5. In the coagulation pathway, we're going to see that, again, this is a positive feedback pathway leading to amplification. Clotting leads to more clotting, leads to more clotting. Eventually, in a normal, healthy individual, this should be terminated by an ultimate negative feedback mechanism. The end result of clotting is the clot, also known as a thrombus. And the importance of a clot is the presence of fibrin threads. And these fibrin threads need to be assembled and cross-linked to each other. That means firmly held in place. We're going to need 12 clotting factors, and one of the factors is calcium. Calcium is going to be a cofactor that helps the enzymes do their job better. Again, like I said, factors 12 and 11 do not require calcium. Many of these clotting factors that I'm going to introduce to you are zymogens. That means that they are synthesized and stored in an inactive form. Anytime you see an enzyme that has a prefix pro or suffix ogen in its name, that tells you that it's inactive and that it needs to be spliced or cut, hydrolyzed in some fashion to activate it. Just so you know, many times when a protein is a zymogen, 2 molecular weights will be given. The first molecular weight is going to be the zymogen. You see, usually there is another long strand of amino acids synthesized that covers the active site of the enzyme. So when you have this long covering of a protein, that is the zymogen part. It needs to be cleaved off to expose the active site of the enzyme. So once it's cleaved off, of course, that means the molecular weight of the active enzyme is going to be smaller, lower than what it initially was. So that's the reason why 2 molecular weights are frequently given. Once these pro-enzymes or zymogens are activated, we simply drop the pro in the prefix or the ogen in the suffix. For example, prothrombin, when activated, is just thrombin, or fibrinogen, when activated, is just fibrin. Now, something else for nomenclature. For example, if you were playing with factor 10 and it was activated and you're writing out factor 10 with the Roman numeral as if it were the letter X, in order to designate that you are speaking of the active form, you would put a little a next to the Roman numeral X in subscript fashion. So that tells the person that you are no longer talking about the zymogen. Again, zymogens, once they're activated, they're going to be proteolytic enzymes. 4 of these zymogens are going to require vitamin K. Vitamin K deficiency and coumadin will be discussed in the next segment. So the 4 zymogens that do require vitamin K are factor 2, which is prothrombin, factor 7, factor 9, and factor 10. are your 12 clotting factors. Factor 1 is fibrinogen. Factor 2 is prothrombin. Factor 3 is tissue thromboplastin or tissue factor, or sometimes it's also platelet factor 3. Now you need to know something. Factor 3 can come from damaged tissues, in which case it's called tissue thromboplastin or tissue factor, or factor 3 can come from platelets, in which case it's called platelet factor 3. They are technically different in chemistry. They are different molecules, but they are still called factor 3. You just need to be mindful that factor 3 can come from the tissue, damaged tissue, or from the platelet itself. And factor 3 is going to have these more like protein and lipid type consistency to it. I will elaborate in a little bit. Factor 4 is calcium. Factor 5 is proaccelerin. Factor 6, like I said before, does not exist. Actually, technically, once we get past factor 4, we simply call them by their Roman numerals. So factor 5, factor 7, 8, 9, 10, 11, 12, 13. Factor 11 and 12, like I said before, don't require calcium. They are contact factors. They simply need to interact with each other to become activated. Actually, it's the prothrombin activating substance that will be made by the extrinsic pathway that can come into contact with factor 11 and 12 and then activate the intrinsic pathway. Or it can be collagen fibers that activate 11 and 12, and I'll discuss this in a little bit. Factor 9 is called the Christmas factor. Interesting note, it was named this because there was a person with Christmas hemophilia, and his name was Christmas, and he got an injection of factor 9 on Christmas Day. So it was named Christmas factor for 2 reasons. So there you have your 12 clotting factors, and the way I remember them shown here on the screen. It says future physiologists take fun classes 5 to 13 years. The future stands for fibrinogen. Physiologist stands for prothrombin. Take fun represents tissue factor, which is really factor 3. Classes stands for calcium, and then 5 to 13 represents your last factors, and we just refer to them as their numbers.